Good afternoon. My name is Jamie Studts. I'm from the University of Kentucky. I want to thank Greta for pointing out that we are indeed the epicenter of lung cancer in the United States, if not the world. But until we own that problem, we really won't be able to make too much traction on addressing it. So we welcome the recognition. But I also wanted to thank Dr. Lefevre for being the one parameter at the University of Missouri for us not being number one, and that's with the lowest tobacco tax. We're darn close to you, but we're working on it. Okay. So I want to acknowledge that this work is really a collaboration with my great colleague at the University of Miami, Dr. Margaret Byrne. So we, both of us started initially studying lung cancer screening outcomes within a couple of smaller trials, both at the University of Louisville, my previous institution, and Margaret's previous institution at the University of Pittsburgh. And we, through that experience and looking at some of those outcomes, we became very interested in the decision-making aspect of it. And so we both, we partnered on a project where we conducted a small mixed method study to examine individual decision-making and parameters that were influencing decisions among individuals who were seeking lung cancer screening outside of a trial context. So these were available in the community at this time. We're talking in probably about 2004, 2005 when some radiology clinics were offering these in Kentucky and in Miami. As you can see, the demand was light, but it was fairly consistent and tended to peak up when they offered coupons. We really did think that this was an interesting opportunity to talk with these folks, to partner with some of these community radiology clinics that were offering this service in order to understand a little bit more about early adopters, what they were seeking and what was influencing their decision making, as well as their knowledge, as well as some implementation procedures as to what was actually going on. We conducted this with 27 individuals, roughly some, half in Kentucky and half in South Florida. And to quickly summarize some of this results from this early study was that the participants were extremely satisfied with their experience. They were regrettably almost completely unaware of any of the potential harms associated with low-dose CT for lung cancer screening at that time. They were motivated to participate because it could indeed reduce their lung cancer mortality risk, that they thought it was a very simple process, very painless and very quick. It was perhaps the most interesting finding was that they did not talk with anyone about this decision. They literally, including their spouses, they just went and did this independently of them in seeking the lung cancer screening. So we, with some of that data, we set forth a program of research designed by both Margaret and myself to explore additional factors about patient decision-making about lung cancer screening, with the idea that we would then start working on a tool that would facilitate informed decision-making with patients, but also other tools and interventions to help educate primary care providers about how to facilitate screening or non-screening. And then finally, a shared decision-making tool, but not actually finally, because we really then started to become interested in a lot of the more diverse range of implementation issues, policy, as well as community initiatives to engage individuals about lung cancer screening options. So early on, we adopted Barbara Reimer's definition of informed decision-making that incorporates understanding of the benefits, harms, limitations, alternatives, and uncertainties associated with screening options, incorporation of strategies to elicit personal preferences and values and beliefs about screening options, that individuals had the opportunity to participate in the decision-making process at the level that they desired, and ultimately they make a decision that's consistent with those preferences and information. But indeed, this does stop short of shared decision-making because it does not necessarily need to occur in consultation with a healthcare provider. We were able to secure some funds from the National Cancer Institute to begin a study using conjoint analysis, which is an experimental survey approach to understanding different factors that influence decision-making about any particular healthcare option or tool. We were very interested in understanding those different salient variables that were influencing potential decisions to be screened. And we used a sequential mixed methods design again, did some more semi-structured interviews to develop the actual instrument, some cognitive interviewing, followed by administering the survey to a nationally representative sample of individuals at high risk for lung cancer. And so we partnered with Knowledge Networks to use their panel, and we did some oversampling of individuals from African American, Hispanic American backgrounds. And we used a broad definition of eligibility because we're focusing on informed decision making, and includes the possibility that we'd be talking to individuals or educating individuals who would not be eligible, and would actually be encouraging them to follow up on tobacco treatment or other strategies that could reduce their risk. So we surveyed 223 initial respondents that met the eligibility criteria, and we had a pretty solid response rate of 94%. And you can see some of the sample characteristics. Indeed, these were high-risk individuals. The conjoint attributes that we decided to include in our survey were out-of-pocket costs, mortality reduction, the healthcare provider recommendation. So either they were against their inclusion, they were for it, that they thought it was a personal decision, or there indeed was no discussion or no involvement with the healthcare provider. And then we had different levels of false positive rates and access to screening. I want to emphasize that we did these attributes in advance of the NLST, so we're still in around 2009 or 2010, but I think we kind of nailed some of them, you know, in terms of our guesses with some of those attributes. So when you summarize, participants responded to 20 different vignettes that iterated these different parameters and to see what factors were actually influencing their decision making. One of the things that you can do is to summarize across all of those choices to get an indicator of just what kind of propensity did someone have toward a lung cancer screening test. And you can see on a scale from 1 to 9, with 1 being no way to 9 sign me up yesterday, you can see that really the general propensity is pretty low. It's about a 3.6 across all those scenarios. The lowest scenario was actually, you know, where there's very minimal benefit, there's high risks, there's high cost. That was around a 2.6, but the highest and the most sort of amenable scenario where there was a lot of benefit, very low harm, very low cost, very high access, you could see that it still only went up to about 5.5 among this high-risk population. So in terms of our overall goal, remember, we're working to this is really conceived of as a values clarification exercise that allow people to reflect and think about the factors that may influence their decision. And so our goal here was to develop this conjoint tool to then embed it into an informed decision aid as one of the preference elicitation strategies. To summarize the broader data in terms of what was influencing these individuals' decisions to or away from screening, you can see that the healthcare provider recommendation, as we anticipated, was by far, you know, the most important thing, as well as cost, you know, pairing up right there. Access to screening was somewhat less motivator, but it still was an influence. And unfortunately, some of the things that we as academics are most interested in terms of the mortality reduction and the false positive rate, were some of the least influential factors in terms of their actual decision making. One of the other things that we did with this was to administer the low literacy version of the decisional conflict scale, which is a very common outcome in decision aid evaluation or decision outcomes. And so decisional conflict is defined as the personal uncertainty about which course of action to take when choices or competing options involve risk or regret or challenges to threats to personal life values. And so what we did was we administered that pre and post the administration of this survey with the idea that if our conjoint is really acting as a preference elicitation strategy or helping them put this information in a context that they can use to make a decision, that we should see some drops in decisional conflict. And boy, did we get some drops in decisional conflict. But, you know, obviously we had a large sample size, and we had a group of a population of people who are generally unfamiliar with lung cancer screening options. And so it was a little bit like shooting fish in the barrel, I admit. But at the same time, we are reaching a population that needs to learn more about this option in order to make an informed choice. And you can see these different subscales from the decisional conflict scale were dramatically reduced. So in conclusion from that first study, or the second study that we did, that the interest was modest to low in terms of lung cancer screening, that the healthcare provider recommendation and costs were a couple of the drivers, and some of the other mortality reduction and false positives were lesser drivers of the decision. But that indeed they were mostly consistent with our hypotheses, and that individuals dramatically favored lower cost and favorable recommendations from their healthcare providers. In general, if you look at the decisional conflict scale scores, you'll see that they were very much unprepared to make a choice about lung cancer screening prior to the decisional conflict scale and before the values clarification exercise, but afterwards that they were able to come to some clarity, and those were generally very low decisional conflicts scores. We then were able to secure additional funding from the National Cancer Institute to continue our program of research to explore the development of Lucas Choices, a web-based decision aid to support informed decision-making about lung cancer screening. And we used, once again, we did some usability testing with our initial draft, which I won't talk about today, but then we're also in the process of conducting a randomized feasibility trial to look at the feasibility, acceptability, and to some extent preliminary efficacy of this tool. The tool is based on our knowledge, empowerment, and values model that we've developed. And in our knowledge section, we work on making sure that people are aware of the screening options and as well as the benefits and risks associated. That we do also have a personal risk assessment, and we're using Martin's model as embedded in our tool as well as calculating their screening eligibility according to a couple of different of the guidelines. The empowerment section works on communication skill development, so encouraging them to talk with a healthcare provider about it, as well as talking to them about shared decision making and helping them to develop some deliberative skills. And we also include the opportunity to do a question prompt list that they can selectively choose from a list of questions and then print that out and take it to talk with their healthcare provider. And then the final component is the values clarification, which helps them explore personal screening values as well as lung cancer screening values. Just a few screenshots from what our tool actually looks like. You can see here that this is the knowledge section, and you can some of the different screen opportunities to discuss some of the different parameters that are available. The empowerment section, as I said, includes the risk assessment that they're able to input and get some feedback on, as well as their guideline eligibility. And then also in terms of empowerment, you can see there's a window that allows you to click the decision prompt list as well as a decision process, and then the question prompt list is also available to individuals who do the decision aid. And then finally, the values clarification step is where they actually do the conjoint exercise and then receive feedback on those attributes that are relevant to them. In terms of the design of the phase 2 study that we're doing, it's a randomized trial comparing of 50 individuals, both in Kentucky and South Florida, and we are comparing against the online NCI lung cancer screening pamphlet or our webpage, and we're evaluating outcomes, decision outcomes mostly at 2 weeks, and then some behavioral outcomes and other outcomes at 4 months. You can see we've achieved a full accrual in a rather short period of time that we're very pleased about. We're at about 90%, or actually 80% to the 2-week outcomes, but we're just starting the 4-month outcomes this week, and so it's premature to be reporting anything other than hopefully be aware that we hopefully do plan to report some outcomes in fairly short order. I want to transition to talking a little bit more about how we're thinking about the use of these tools. And one of the things is that really decision tools can be used at various phases of the screening process. And it's not that we need just one tool to do one thing to facilitate shared decision making, but actually there's a need for multiple tools along the process where they can be used to achieve slightly different outcomes. And so you can think of tools that promote awareness in the beginning, pre-consultation tools that might help people prepare to talk with their healthcare provider, a tool like Bob had just mentioned to be used in consultation, but other tools, what if during a consultation you didn't come to a conclusion and actually that there's remaining ambivalence, that someone could be sent back to another tool to perhaps explore the decision more prior to another consultation, as well as tools that could be implemented to facilitate and maintain adherence. And so in terms of Lucas choices, what we think that we're targeting is those individuals here in a public health informed decision-making approach, that our tool has very broad coverage of the issues. It's long. If any healthcare provider tried to implement it actually in a consultation, I'm sure I'd get hateful emails. It's not what it's designed to do. And this is really targeting information seekers, people who are actually trying to understand this choice, versus those like Bob has talked about in some of his PCORI work that introduce the coverage, that are a little bit shorter and provide relevant information, versus the decision aids that occur in consult in the encounter that has focused on CMS coverage of information, very brief and very tailored to the context, as well as something we don't think about a lot, and that's those post-consult ones where we think that Lucas choices might also be helpful if indeed they don't, a person does not come to a conclusion after a consultation. And so one of the things is that we're thinking about now in terms of as we transition to thinking about decision-making and informed decision-making approaches, that there's a lot of effort that we have to undertake to really help our population, our communities understand the options. And one of the things that we are also thinking about is that really informed decision-making principles need to either be the foundation or possibly the umbrella concept for which we do all of this work, that all of our work is designed not necessarily to increase uptake, but really to help people make informed choices. And we think that that has some very important implications for long-term adherence. Maybe we can take a vote as to whether people think it should be the umbrella or the foundation later. And so we really build on some of the work that Dr. Lisa Carter-Harris has done, looking at individuals who participate in screening as well as individuals who are candidates for screening, and highlight some of the concerns about stigma and distrust that are almost inherent to this population of individuals, and that efforts to market these strategies that tend to be fear-based or totally focus on the benefits without mentioning any harms and other persuasion techniques are actually undermining people's access or desire to pursue them, because remember, this is not the population that is energized, activated, and motivated. This is a different population of individuals who engage our healthcare system differently at best. And so we think that focusing on informed decision making may play a role in helping getting more people engaged in screening and keeping them engaged in a way that they feel like they've been supported and empathically met. So a part of what we're doing is also thinking about these socially responsible marketing efforts in a project that's funded by the Bristol Myers Squibb Foundation called the Kentucky Leads Collaborative. And we're trying to develop principles that we think could be embedded or into marketing strategies that first, the basics of convey accurate information about screening, encourage engagement with a healthcare clinician, that the messages seek a balanced presentation of benefits and harms, and actually avoid fear-based appeals that might engender distrust and stigmatize the group and perhaps even push them in a direction away. Regrettably, I don't have data to support this effort yet, but we're looking into these approaches. And I want to conclude with the idea that I really do think we need to emphasize a couple of things, that this group is different than our normal screening populations, and thinking about them differently from the very beginning is an important piece of understanding who they are and designing our programs to meet their needs and to support them. And ultimately, we're all in this to reduce the mortality from lung cancer. And perhaps the best ways to do that are actually informed and shared decision making and patient counseling that helps engage them in the process. And we want to do these a lot for many reasons of patient autonomy and patient engagement, but I actually believe that the trusted relationship with screening programs is what might be the most important thing to leverage, because really there's no way to get from the high-risk lung population to reducing mortality unless we have adherence. And that's long-term adherence and engagement with these programs where people feel like they are consistent with their values and beliefs, and it is a good thing that's actually benefiting them. And we really have to do that in order to achieve that interim outcome, which I don't think we've focused on quite enough in terms of the long-term impact of, because I'm not an epidemiologist, but I don't think that there's any way to get to a 20% relative reduction in mortality with a 30% adherence rate. And then along with that, we use this trusted relationship to not only implement empathic, evidence-based tobacco treatment strategies, but also if people are making the effort to go through a process of seeking lung cancer screening because they're concerned enough about their risk of lung cancer, why not incorporate messages with regard to radon exposure and other secondhand smoke exposures and other things that could potentially reduce their personal risk of developing lung cancer or members of their family's risk of developing lung cancer in the future. So those are some of the things that we're thinking about, and hopefully that can eventually lead to some type of mortality reduction as well. I want to thank my colleagues and collaborators who've participated in this research, the University of Kentucky, Miami, Pittsburgh, Lung Cancer Alliance, Memorial Sloan Kettering, Maine Medical Center, Minneapolis, VA, Michigan, Arizona. So, thank you.